causes of orophageal dysphagia: the cerebrovascular accidents, amyotrophic lateral sclerosis, Parkinson's disease, myasthenia gravis. And if you talk about the esophageal, there is top list is aphasia cardia. Then we have non-aphasia motility disorders. We have strictures, we have bands, we have a GERD, we have a neoplasm, which causes the obstruction of the esophagus any place, either upper one third, middle one third, or lower one third. Or it can be a esophageal diverticular, foreign bodies. Mostly people they take a small disease, they take swines or something like even people they take acid also. Washroom में पड़ा होता है हार्पिक वगैरह से और तो take sometime the psychological patients or those people who problems होता है. Mostly they take these things, to die there, because वो होता नहीं है, and it results into a very severe stricture in the esophagus. Infection esophagitis और ये gastric injuries. आगे चलो, ये नीचे नहीं होता क्या? कैसे आउट होती है? नहीं, वो नीचे होता है इसमें। नीचे तो देखो, आपको नजर नहीं आ रहा तो So in esophageal disorders, we have a mechanical obstructions. If it is intermittent, that is because of the ring and cracks. होता है obstruction relieve हो जाता है, होता है क्यों होता है? और जो progressive होता है, that is because of the stricture or malignancy. Malignancy में क्या होगा? When you exclude the obstruction, nothing will go down. In motility disorders, we have intermittent, which is because of the esophageal spasm, and in progressive, we have aphasia cardia and we have scleroderma. So this is the difficulty in propelling the food from the esophagus. It arises in the body of the esophagus either due to a mechanical or a motility disorder. Now these are the diseases which causes the obstruction. We have aphasia, we have non-aphasia motility disorder, we have strictures, webs, gastroesophageal reflux disease, and extra reflux disease. Neoplasm, esophageal diverticular, foreign bodies, pill-induced injuries, infectious esophagitis, and gastric injuries. This is a primary esophageal motility of unknown cause characterized by the insufficient lower esophagus stricture. वहाँ क्या होता है कि there occurs a stricture down and the muscles which are all tight around the esophagus at the lower junction. So this is maybe a hereditary, degenerative, or autoimmune or infectious cause. आगे चलो. The symptoms are dysphagia for solid and liquid both. When the disease is progressed, first it is due to the obstruction to the liquids, then after it becomes solid and liquid both, they cannot go down. If it goes down, it takes hours and hours for food to go down, and there is a dilatation above the lower esophageal junction. We will show you the dilatation of the photograph. We have a regurgitation when nothing is going down from the lower esophagus. Food is like in the upper part of the esophagus, and sometimes the regurgitation occurs, patient throws it out. The chest pain too, right? People they cannot differentiate chest pain with this diet. But if they have a history of this regurgitation, then one can say this is because of the obstruction of the esophagus. Initially, it may be for solid, and later on, if the disease is progressed, then there is an obstruction of the fluid also. Most people have dysphagia for solids and liquids at the time of presentation. Regurgitation is 75%. Aphasia becomes a greater problem as this esophagus dilates with the progress. When it dilates upward, it becomes more aggressive. Choking pain occurs, coughing may awaken the patient from sleep. When they are lying down, when they are lying like if you straight down, the food can go backward and protein content they can get up in the middle of the night. Chest pain 40% weight loss, the 60 is why weight loss, but they are not eating. The food is not going down, so they don't eat. Sometimes they don't come to the doctor. Just they are just like educated to go to the doctor. Daily disorders, isotogram with fluoroscopy is the best initial diagnosis. Are Now, this test will reveal the passenger in the distal treatment of the subject. In the upright position, there will be a poor emptying with retained food and saliva producing a heterogeneous air fluid level at the top of the barium column. We show you now. Other thing, pointer that. You can see this. This is the constriction at the lower end of the esophagus, and then here is the dilatation. You can see here, lower esophageal sphincter, this one. It's tightened over here, there it is more tightened. Are we clear? Now see, this is the bird's peak appearance on the X-ray, on the barium beam. You can see the food is there and there's air over there. This is a gold studded X-ray, you can diagnose for the oxygen or the aphasia cardiac. Are we clear? That's the portion of the G junction, lower esophageal junction where there is constriction. And now endoscopy, when I do endoscopy, it's a pinpoint hole over there. You see this pinpoint hole? I don't know why do not know better than that. Alright, दूर में लगाइए क्या? आगे चलो. This chronic disease messes with the sigmoid line. Now when disease becomes more chronic, there's more dilatation beyond that lower esophageal junction. So it gives like it's one sigmoid-like tortuous thing. You see the debris of the food all over here. Here is the obstruction. Are we clear? Smooth development of the lower esophagus, leading to closed lower esophageal sphincter. Presence of impediment diverticular nature of the place. Are we clear? The same thing. See this? You can see the bird thing here, the food, air. Same thing over there. They're also same. Are we clear? Now, what are the other tests? Yeah, they do manometry also. In the body of the esophagus, A pressure is always present. Definitely, when there is no pressure, the food is not going down, there will be A pressure. All solos are typically with low contraction and amplitude. Are we clear? Same thing. This is the pinpoint here. This is esophageal dilated, so much dilated. Retained fluid and debris are there. These are the debris in this fluid. There are non-relaxation of the lower esophageal junction. Asynchronous contraction and non-peristaltic movements, fibrotic and atrophic tissues are there. Retention and stagnation of the chronic food is there. Retention, esophagitis can occur. So this food retained over there, you can have esophagitis also proximal to that lower esophageal structure. Now what is the therapy? They say there is a medical therapy and pneumatic dilatation of the lower esophageal junction. Pneumatic dilatation, when they do endoscopy, they pass a balloon inside and they inflate with the air so that the constrictor muscle it opens. That is called dilatation. They do with a less size balloon, then after that they do bigger than that. So in 2-3 sittings they do a dilatation. Patient doesn't need surgery sometimes. But in my experience of protein surgery, I have seen they don't react to the dilatation. They need a definite surgery. One time we have seen a patient, they did a dilatation and they perforated something. So in that case, you have to do a surgery. Can end up into esophageal. If the tear is more thick, but if the tear is very small, you can go to a laboratory and you can do anything on esophagus. So these are the complications of dilatation. You can rupture the esophagus, you can go down, you can rupture the stomach also. But mostly the esophagus is ruptured while doing a dilatation, endoscopic dilatation. Another one is surgical myotomy. So this is botulinum toxin. This is, we do this one, surgical myotomy. If the patient has come in early stages, then they can do a dialysis. If the patient is a chronic disease, then this dialysis will not work. Then they will end up into a, if they now see, you have to be a very particular every field. अब वो एमबीबीएस नहीं है आज आप एमबीबीएस कर लिया जनरल सर्जन बन गए you are going to go in every field of the surgery. No. Now there are separate thyroid surgeons, separate upper GI surgeons, separate lower GI surgeons. They are called colorectal surgeons. अब वो फील्ड जो है वो डिफरेंट है वो डिस्ट्रीब्यूट होती है. You cannot be a master of all. So people who are good in endoscopic surgery or endoscopy, they should do the dilatation of endoscopic dilatation. Otherwise, if you are not capable of doing it, send it to the higher center where people are doing endoscopy. हमारे सिविल में एक एंडोस्कोपी सूट बना है सिंध इंस्टीट्यूट ऑफ एंडोस्कोपिक सर्जरी एंडोस्कोपी बड़ा अच्छा शानदार बना है. यू शुड गो एंड विजिट वन डे ओवर देयर. आगे चलो. वहाँ सारी एंडोस्कोपिक ट्रीटमेंट होती है, ईआरसीटी होती है, डायलिसिस होती है, स्टेंट पास करते हैं. The two most effective treatments graded pneumatic dilatation in the surgical myotomy. आगे चलो. मेडिकल चार्ज में ये नाइट्रेट्स कैल्शियम डॉक्टर देते हैं बट वी डोंट बिलीव इन इट. आगे चलो. Liver transplant is good short term results. 2 to 5 is risk of mortality. 2 to 4. Even if there is a 0.5 percentage of complication, you should not do it. 5% is more if you are not capable of doing it. जरूरी काम से एंडोस्कोपी करना शुरू कर दिया. इसमें जो एवरी एंडोस्कोपी इज डायग्नोस्टिक प्रोसीजर. दिस इज therapeutic maneuver, therapeutic treatment. So there are two different ones. One is diagnostic, one is therapeutic. You can be a good in therapeutic, you can be a good in both cases. So they are the best one in therapeutic, they should do it. Even their hands also there are 2 to 5% of chances of perforation. Balloon dilators, these are the three, they use first 3 or then 3.5, then 4 centimeter size balloon. After pneumatic dilatation, gastroscopic studies are done by very following to exclude these of the problem. Now see, they do, even when small perforation can be there, which can be only recognized by very following. वहाँ पे आप एक्सरे आ जाएगा. But what we had in 2004 and 5 in China, they saw the whole abdominal gut inside. So they did a big hole and the endoscope went inside the abdominal cavity. आगे चलो. That is the balloon dilatation. So these are the sizes 3, 3.5 and 4 size. So I start अगर they डालते हैं, then they dilate it, and then they see if the dilatation is there, the muscles are being broken, then they use another size one. So this way they dilate this portion. Now these are the muscles which are around this. There are two kinds of muscles. One are the circular and another longitudinal. What they do is they just stretch the muscle, the whole structure. With that, the muscle fibers are stretching. If not a cell, then they can go out and perforate. आगे चलो. Now, if the medical, this one, the endoscopic treatment is failed, then you have to do the surgical treatment, which is called the surgical myotomy. Anti-myotomy across the lowest vagina. So, पिछली वाली slide चलाना please. Now, what they do is here. Now, suppose you forget about this balloon. There is same esophageal membrane over here. What they do is they just split both the fibers. The longitudinal fibers they open it, and then they open the circular fibers also. They leave the mucosa. Now in that case also, you have to be very particular. This is suppose so like that. These are the longitudinal fibers. You have to split it out, open it like that. अगर आप ये यहाँ कीजिए, ये open हो गया suppose, ठीक है? Now it's open. Now you see the circular fibers. You have to go from under this fiber very carefully because there is a mucosa inside. Mucosa inside. If you rupture the mucosa, you have perforated it. So in surgical treatment also, you have to be very careful. You have to go under the fibers. We have a special scissors called sugar baker scissors, which we pass inside the fibers, which is डालते हैं. Now that the scissor has two jaws, no? Upper and lower. So the lower jaw is insulated here. The current doesn't pass from beyond this. So we go. This is mucosa. We are over the mucosa, and this is part of the scissor which is insulated. This is metal part which is not insulated. This one is also a metal part, but it is insulated down with a cup-shaped structure. That is called sugar baker scissor. And when we do a diathermy, we cut the fibers like this because they bleed, no? So you cannot stretch like that. There is a bleeding because it is difficult to find the retracted muscle fibers. So we diathermize it and we cut the fiber. So while cutting, you have to take care of the mucosa. It should not be perforated. So in this way, the fibers they are separated. We can see a popped out mucosa. So that means your lower ischemic sphincter, which was tightened, now it has opened. And you feel so good when the patient come to you back in a revisit. They say you कि हमने जो है वो खाना खाना शुरू किया है महीनों के बाद. You feel so good that you have done something big just at the type of surgery. आगे चलो, आगे चलो. इससे पहले चलो, वापस आ. So we do laparoscopy. Mostly we do laparoscopy. Nowadays, every surgery is being done laparoscopy. Even the rituals and every kind of abdominal surgery or chest surgery, that is done by a laparoscope. So you who are going to become a surgeon, they should think of the laparoscopy. You should concentrate on that laparoscopy surgery. उसके skills आने चाहिए यहाँ. आगे चलो. Sometimes if you have not done properly stretch the muscle fiber, अगर आपने अच्छी तरह muscle fiber stretch नहीं किए हैं, उस length of the defect को, if you have not opened it properly, you can get again the same symptoms. So most of the time, 50% patients are like they have a recurrence if you have not done properly. So the job is of a surgeon. You should properly find out how much portion of the esophagus and gastric portion is constricted, so that you can open the all part of that constricted part. If you not halfway open it, again that will constrict and there will be a obstruction and there will be a dysphagia and the food will again accumulate over there. So these are the impressions have been done. There is another radiograph here. See the corkscrew appearance here. Deep like tapering over down. The same thing here. Manometry, prolonged high amplitude, non-facial movements are there. They are non-facial movements. Now here, this is like the pressure is a little bit over here. So there is an obsession over here. This is also not clearly another common melomatic diagnosis in non-cardiac chest pain defined by the high amplitude pressure. The distal esophageal contraction amplitude is less than 30 mm of Hg if 30% or more of the breath swallowed. A food bolus may not be effectively transported. Sometimes there is a very difficulty food bolus passes. In the beginning, you have to tell them to take a soft diet so that mucosa that becomes a little bit used to that bolus of it. Sometimes you pass a hard food that might mucosa come out and puncture it. reassure the disease is not heart disease. Medication, you can give a medication, calcium blockers or anticoagulants, but not completely effective. Other surgery is the only option. Dilatation or surgical myopathy. Other Another cause is scleroderma. In that case, also you get a obstruction over here. Dilatation behind this. See this one. Other endoscopically reflux is esophagitis. Now, when there is the obstruction down, where reflux occurs, the food comes backward. All your esophagus becomes infected. You can see the redness over here. This is all the reflux esophagitis. So what does is called people will get most of the time, not necessarily that this is because of the cardiac. Sometimes there's a relaxed distributor. There's a hiatus hernia. If you remember, if you've heard about the hiatus hernia, tonight, if that will go when the left and the right fruits of the esophagus is down, it becomes loose. So the your sphincter doesn't work properly. It doesn't close properly. The food which you are eating in the stomach, late night it comes backward when you lie down. That causes refluxes of that. Strictures also can cause a dysphagia. Now these are the any loss of the lumen area. Definitely when there is stricture, the lumen area is decreased. The normal insulin may have 20 milliliter diet. Now the normal use of it is 20 ml. It can reduce because of anything, whether stricture or carcinoma. The phenotypical symptom of stricture is dysphagia. So all have a dysphagia. They will tell you, खाना खाते ही अटकता है dysphagia. आगे चलो. So they say even less severe stricture they can cause dysphagia. आगे चलो. Now this is etiology of dysphagia. Acid also, acid reflux disease, pill reduced, chemical post nasogastric tube. Sometimes when nasogastric tube is inserted, even the post operation, अगर आपने देखा होगा, कोई भी abdominal surgery होती है, उनके पास a nasogastric tube. So that whatever if they have done enough promotion beyond the stomach, so उस तरह से release करने के लिए they don't want it abdominal stomach fluid to pass on through that passage of the nerve muscle. They put an empty tube so that it can come out, should not go through the passage of the nerve muscle. So क्या होता है जो हील होता है proper. So if you keep that tube longer behind the oral canal, inside the esophagus, there sometimes stricture occurs. That is also one of the cause. Sclerotherapy, radiation also. They get a breast surgery का होता है, they get a radiotherapy. With that radiotherapy also, we can get a stricture in the esophagus. Then esophageal gastric malignancies, CA esophagus, CA stomach. If there is a CA stomach lower down, it can ascend upward in the esophagus, or C of the stomach itself, esophagus itself can cause obstruction. Congenital also there are anomalies, surgical anastomosis, systematic inflammatory disease, और एक भी है वो आगे चलो. Extensive effect पार्ट जो होता है वो होता है pulmonary mediastinal malignancy. Any malignancy either in the mediastinum or lungs, they compress it from outside. Then anomalous vessels and aneurysms also, they also compress it out. क्या प्रॉब्लम है आपके साथ? और पीछे देखने आगे the second last row. Then we have metastatic submucosal infiltration, breast cancer. That also can go inside and can metastasize into the esophagus. आगे चलो. Ingestions are most common with acid. I told you acid. The ingestion of the acid that also can cause stricture. Tactic cause accounting for the majority of the cases, 60-70%. आगे चलो. Now see this picture over here. Yeah. The bolus is stuck over there. It's not going down. There is the picture. That's the stomach. This is the gastroesophageal junction. आगे चलो. Same esophageal dilation, there are several different types of dilators using mercury-filled rubber, melody dilators, wire-guided, rigid, semi-cleared dilators, and there are metallic also. Sometimes when there is a benign stricture or the esophageal tumor also, they get an obstruction. Patients are inoperable. The disease is extended beyond the esophagus, it's in the liver, metastasis, stomach, everywhere, where you cannot operate. So, just to give a patient a good life of eating and drinking, they pass a metallic stent endoscopically. जो metallic होता है वो एक अंदर जाके खुल जाता है. It doesn't collapse. पहले वो red rubber के आते थे, now they are metallic ones. Which the inside open, then they don't close. तो वो जो ऑक्सीजन होता है खोल देता है. Actually the patient eat and drink. Life is only बुरा लगा जिसकी लिखी हुई है, because we are not operating in inoperable place. Metastasis everywhere, but we have to give him a really good life so that he can eat and drink. So they pass a metallic stent also. अभी चलो, ये देखो wire guided severy balloons. आगे चलो. The complications, same I told you, perforation are there, bleeding is there, bacteria, you can pass infection also. Those with radiation-induced pregnancy are at the higher risk. Definitely, they are already on the higher risk. To minimize risk of proportion, the rule of threes applies. आगे चलो. That is no more than three sequential dilators should be. You see, I told you. Once you should not, that is no more than three sequential dilators should be performed per session. ऐसा नहीं कि आपने एक बार किया तो शेड्स लगे हुए हैं आपको और डायरेक्ट पता लगा वो पड़ गया था. तो दिस इज वन ऑफ द रीजन दैट यू शुड नॉट डायरेक्ट मोर देन 3 times. The goal of esophageal is to obtain an objective diameter of the greater than 15 millimeter. इतना हो कि आप 15 मिनट से ज़्यादा हो, एटलीस्ट वो you can eat or drink liquids first. Approximately 90% of the patient dilated to 50 minutes have no recurrence at 24 months. They can get recurrence again, but up to 44 months, they have done a study that they don't get a recurrence. आगे चलो. If you have opened it 15 minutes, अगर आपने 10 minutes खोला है, तो वो नहीं ऊपर से खुलेगा पूरा. The refractory esophageal strictures are defined by lack of response to two more dilators. अगर दो और से ज़्यादा हो जाता है तो फिर भी कभी नहीं आता. The cause for refractory strictures can include ongoing insults from the pills or non-steroidal anti-inflammatory drugs. NSAID जो होते हैं ना, ये भी करते हैं आपको, esophagitis करते हैं, gastritis करते हैं, they can give inflammation, then they can occur strictures also. इसीलिए जो reflux esophageal होता है, they don't advise NSAIDs. आगे चलो. PPR, the superior to H2 blockers, देते हैं treatment of the refractory stricture includes elimination of the offending agents, pills or acid, and gentle dilatation. आगे चलो. They can give steroid intraluminally, but nowadays they don't give it. Surgery may be considered in those who fail to respond to aggressive medical therapy and dilatation. Aggressive लिखा है उसमें कि अगर आप डाल रहे कर रहे हैं डायलेशन, एक दफा कर दिया, दो दफा कर दिया, नहीं हो रहा तो रिपोर्ट टू सर्जिकल टीम. आगे चलो. और पेरेंट्स esophagus में भी आपको you can get esophagitis and acid reflux errors. आगे चलो. This is normal esophagus and this is parasitic. This becomes whole big size. आगे चलो. So that's the cancer. You can see this. Now this is the wall of the esophagus. Now these are the tumors, they grow into the wall, and then they come forward and then they block the whole lumen. They can come from one side, they can come in the whole circumference also. So they can एक side से दूसरी side से. This is at one side only. Fungal type of mass. Look at this. Now this is the stricture. They call it apple core. Apple खाते हैं ना, जिसमें वो छोड़ देते हैं, वो आपको दिखाएंगे. आगे चलो. Malignant tumor esophagus, they also cause the same thing. आगे चलो. that includes esophageal squamous carcinoma, adenocarcinoma, other things. Any problem? They also got the strictures and cancer, other things. Dysphagia is the present in component 80 to 90% patients with esophageal carcinoma. 100%, 80 to 90%, or 100%, they come with the cancer also. Early symptoms are sometimes non-specific. Retroexternal disorder. They come and tell you, सीने के पीछे यहाँ पे दर्द होती है, यहाँ पे बंद होता है. That is all retroexternal severe pain. आगे चलो. Definitely, when the tumor enlarges, the dysphagia are more aggressive. The whole human is blocked. Patient cannot eat and drink. आगे चलो. Diagnosed by barium swallow, esophagoscopy, esophageal biopsy, or brushing from the cytology, technical CT scan also. That is the barium mercy. You can see here tumor over there. You can see here also. This one. Apple core appearance. See this? ये वाला. ये normal esophagus. This is gastroesophageal junction. Here is the lower end of esophagus. You can see this thin, this tumor is left only, and beyond this there is all tumor. Apple खाता है जहाँ तो उसमें बीच में वो स्टिक रह जाती है वो ये है. This is called the apple core appearance. आगे चलो. Surgical is the standard treatment for early esophageal cancer, stage 1, 2, and most of 3 also. Now this depends on that you should not have a metastasis anywhere around. Then you can operate. Or if it is at the carina, अगर आपका it is adherent with the trachea, that's very difficult. You cannot separate from the trachea. Once we have seen the case, they were doing a transhiatal esophagectomy. Transhiatal means they open the abdomen, they go inside the hiatus. Between two lungs, as I told you, there is a hiatus, left pleura and right pleura, there is a hiatus. So they go under this hiatus and they call it transhiatal esophagectomy. So while doing that, they just cut the trachea. The patient died on the table. So if it is more in the trachea, they don't do it. Or if it is there are metastases in the liver or other areas, they don't do it. Then they just pass a stent for patient to eat or drink. I will give you some time. They cannot pass stent. फिर कैसे patient को nutrition मिलती है? तो क्या कर सकते हैं? ये ऑप्शन मुंह से बिल्कुल बंद है. क्या कर सकते हैं? और ऑप्शन नेजो कैसे होता तो इससे जल जाता ना. We do a gastrostomy. Gastrostomy. बाहर से ट्यूब डाल देते हैं gastrostomy के साथ. At least patient should have a feeling of fullness of stomach. उसको खाया पिया है, लगता है हमें patient full. You can get a nutrition from there also. अगर वो नहीं करते then you are get nostomy also. Feeding getinostomy. तो पढ़िएगा जाके. Feeding gastrostomy, feeding getinostomy. These are the other options for giving food to the patient. If there is a total obstruction and inoperable, or even you cannot pass a stent, then we do these two procedures. Either gastrostomy or getinostomy. आगे चलो. That's it. आप लोगों का अटेंडेंस हो गया? Anything more to ask? कितनी लगानी है?